Do we have a great show for you today? This is No Spin Live, and we're going to be talking about boob veins, truth in advertising, and women aren't being warned about something, and we're going to tell you about it. We've got some great plastic surgeons, internationally plastic surgeons here to talk about these topics. Dr. Jason Pozner from Boca Raton, Florida. Dr. Kristi Hustak from Houston, Texas. Fellow countryman, high five, Kristi. And then Dr. Dan Vecchio from Boston, Massachusetts, DDV. Go Patriots. And one of Dan's fellow Italian countrymen joining me here in the studio, Dr. Adriano Santorelli from Naples, Italy. Thank you for joining us.
Thank you very much.
We have some great topics to talk about. Let's lead it in. Jason, you ought to lead us off on this one. So you see a lot of women, especially sometimes they get implants or they just have a lot of superficial veins that they see in the breast and they don't like it. Sometimes it shows up more after pregnancy. What can we do and what would you recommend for this problem?
Got it. So, it's a multifactorial approach for this. One, you can do sclerotherapy for breast veins. Not a problem. It does really well, treats the veins, makes the skin look beautiful. You can use lasers. If the vessels are below a certain size, you can definitely use, my preference is an ND-YAG laser. I use the Cyton for this, and we can shrink down the vessels. But if they're too big, it probably doesn't work and you're better off with sclerotherapy. Other options are to fill around it with fat or other fillers to kind of disguise the veins. But I'll usually go after the veins with usually a laser to start with if they're not too big.
Del Vecchio, are you voting for fat for this problem?
I have not used fat for this problem. I have never treated this problem, so I'm going to take, this could be the first time I just shut up and take a pass.
This is the first time that you're going to not have a comment? Oh my God.
Like a Patriot's safety, never seen before.
Well, think about it. We may come back to you if need be. Kristi, what do you think? What do you think about this?
First thing is to stay relatively conservative with your breast aug. So if you go ginormous and you really stretch your pocket, it's obvious. You're going to have to stretch and engorge that tissue, and they're going to become more superficial, and you need more blood flow to support it. So I think one answer is don't go as dramatic. But obviously, I live in the state of Texas, so bigger the better, right? So it's going to happen. So fat grafting, I love fat actually for this. It kind of masks them a little bit. But the other option is sclerosing. I've only done that a couple times. I've had marginal success. Never tried the lasers. I think that's a great idea, but fat grafting is my answer for this.
Adriano, do you see this problem in Italy?
Yes, we have this problem, but we have two kinds of patients. The patients where after surgery, they have a beautiful breast with the veins. For this I say, why you talk about the veins? You have a beautiful breast now. The problem is when you have poor breast and the veins. This is a big problem, and then it's not simple to solve, because in my experience the laser is not works so well, and the fat is, I don't propose another operation for this problem.
Jason, so some of these veins are pretty big. What's your go-to for a bigger vein? It's not like a little spider vein.
No, if it's a bigger vein, usually you're going to tie it off or you're going to sclerose it. But for the smaller veins, a laser is great. But over a certain size and flow, the laser is just not going to really close them down right now.
All right, well, that's great stuff. Let's move on to the next topic. This comes out of Virginia. It's about truth in advertising. We've talked about this topic before, but this is about a lady that had major complications after eyelid surgery and then found out her surgeon actually wasn't a surgeon, wasn't trained in surgery. What's the solution for patients to know that they're actually going to a surgeon who's been trained in surgery to do their procedure?
ASAP's has to have a public service campaign on their Instagram page and drill it on their website, which is inexpensive. We're not looking for television spots during the Super Bowl, but to educate people who are just not intelligent enough to do their own homework. The end.
Adriano, do you have this type of issue in Italy where people are not trained but they're performing procedures, and is it a problem there?
Yes, this is a big problem. We have gynecologists that they do breast augmentation, urologists that do abdominoplasty, and we are probably in Naples doing a society only for fellow surgeons specialized in plastic reconstructive and aesthetic surgery. But it's not simple, because the biggest society in Italy are not only for plastic surgeon. If you are great recognized surgeon, you can stay in this society. But we won't do another society only for plastic surgeon. is because we want to educate the patients. The only solution is educate the patients. How? It's not simple, because the patients think that aesthetic can do every surgeon. But we, with Instagram, social media, paper, I don't know, all is important, but we must educate the patients in this moment. It's a terrible problem in Italy, and South Italy especially.
And the people that suffer are the patients.
Yes, yes.
Okay, Kristi, I got a hypothetical for you. So this dude goes to the Sharper Image, buys himself a drone, and he says he's a pretty good drone pilot. So he goes to Delta or American Airlines, says, I'm gonna fly your 747 now. They're gonna say, sorry, dude, that dog doesn't hunt. But that's exactly what's going on with this. People are not trained, but they're going to a weekend course, and then they're gonna do a tummy tuck, or they're gonna do an abdominoplasty, and they're an ER physician that's never had any formal surgical training. Why is this happening?
It's a huge problem. It's a problem because everybody wants to be an expert. And I mean, I empathize with our colleagues who are just trying to survive, right? As insurance reimbursement goes down, everybody's trying to find elective money. And so I empathize. But, you know, even more than these docs, which definitely bothers me, you know, these ER docs, whatnot, is the mid-levels now. That's another huge problem. You know, the nurse practitioners and the physician's assistants, who now in 23 states have independent practice, are now regulated by nursing. They're not even regulated by the board. So I know nurses that are doing liposuction now. And patients just don't know. They say, oh, it's cheap, it's awake, it must be safe. They have no idea the bad things that can happen. You know, the general lay person is not educated enough to know, and they're using words like board certified. You know, what kind of board is this? You know, and so patients hear, oh, I was told board certified, but you need to ask in what? You need to ask, you know, even if you operate in private practice in your own surgical center, I think the best question you can ask is, do you have hospital privileges, and are they admitting privileges where you can operate in this liposuction or this breast aug or whatever it is? Because that's telling. If you are an emergency room doctor, you can have your own surgical center and operate, but you cannot get hospital privileges to operate there. So if they cannot operate in a surgical center that's accredited, that's hospital based, or at least have privileges, because every one of us that are board certified by the American Board of Plastic Surgery have to maintain that safety standard, then that's kind of your answer right there. They probably aren't a board certified plastic surgeon. Yeah,
I think those are some really great points, Kristi, and probably the board certification is tricky because there's other board certifications, and as you said, you can be a higher level advanced degree individual and you can't figure it out. But I think some of the other things you mentioned are really good. Jason, what else can patients do to be safe?
I like that plane analogy you talked about, because, you know, imagine now what they have to go through to fly a plane. Okay, commercial airline pilot, how much training, how much regional airlines before they get to the big leagues. And then how do you rate airline pilots besides safety? It's how many hours they have in the air, how many hours they're flying. And that's directly related to how much experience we have doing these procedures. Now, Dan has done 50 million buttock augmentations by now. Okay, so would you rather have the ER doc who read about one, or have Dan, you know, do your buttock augmentation? I think there's a level of training and a level of sophistication that happens from doing more cases. If you read anything by Malcolm Gladwell, you know, he goes through all of these in all of his books, Outliers and other books, that you need a certain amount of experience to be able to become expert at what you're doing. And, you know, Plastic Surgery Channel has the world experts on it who have a lot of experience. You know, I'm definitely a different surgeon than I was 20 years ago. I fight over millimeters in my head when I'm operating now. But before, oh, it was a breast aug. That's easy. You know, put an implant in. Now it's, do I cut that muscle 1 more millimeter? Or what about that attachment in the blood supply? So experience matters.
Del Vecchio, why is it, it's the analogy of flying the 747 is the easy one to understand, and people go, oh, yeah, absolutely. But that doesn't translate when they do cosmetic surgery procedures. Why is that?
There's only so much you can do, and it's all like you've said so many times. If it's not about the money, it's about the money. So at the end of the day, you've got a population of consumers for a wide spectrum of intelligence and a wide spectrum of diligence. And you've got a penalty for performing medicine without a license, which doesn't exist. Like in Italy, the crime of performing medicine without a license is a fine. It's not even prison time. In the United States, it's not a big deal unless you kill somebody. So the penalties we can't change. We're not going to change the laws. The only thing we can change is education. We can only help to educate these people. And again, I say, ASAP should spend their money, instead of having like Instagram pages which show how great their presidents are and their president-elects, and showing, doing fat grafting and showing them on picnics with their kids. They should have a campaign that shows the dangers, just like when you buy cigarettes and it shows a penis that can't get erect or someone with a tracheostomy. You've got to show some disasters and say, like, look, you want to go to a non-board certified plastic surgeon, this is what you get. This is a case done by a non-board certified. That kind of stuff gets people's attention.
The problem is that the brands, the company, they have all the interest to grow in the market with the not specialized doctor too. This is the problem. They sell the implants, the fillers, the injectables, the devices, doctors that are not plastic surgeon.
Yeah, and that's a good point. I mean, there's part of it there. I do think the grassroots approach that Vecchio is talking about is probably one that needs to be further explored. But there actually is a company here in the United States that elected only to sell breast implants to board certified plastic surgeons compared to the other ones that sell to everybody. And so, that's stuff that we can talk about for a long time. But I think those points are well taken, and I'm sure we'll be talking about this subject again. So let's move on to our last topic. This comes from the Daily Mail, so I think you have to consider the source, number one, but this is about breast implant ALCL, and they're saying that women aren't being warned or informed about this. I have my own thoughts on this, but Jason, what do you think?
We've been through this a lot of times on Plastic Surgery Channel, and ALCL is a real problem. It is something that there's a lot more literature available. There's a lot more literature available for the patients, and any Google search will reveal quite a bit on it. So I really think that it's in our best interest to explain this to the patients when they come in for consultations and direct them to the right sources for further information on the web. I don't believe that it's not being told to the patients. I believe we all are telling this to our patients at this point.
First of all, the Daily Mail it's there for shock value, and the source, it is what it is, and their track record is what we know. But 10 years ago, nobody knew about this. So yeah, maybe 10 years ago, and the average time to contract this is 8 to 10 years. So there may be some patients that are being diagnosed that weren't told about it because nobody knew about it. But certainly in the past 5 years, people have been aware about it. And I think most plastic surgeons are informing their patients about this. What do you think?
I think it's in every consent, and I do talk to it about patients, but I don't harp on it. This isn't something that I say, hey, listen, if I put this in, you have a 1 in 30,000 chance, if you put a textured device, for example, that you're going to get anaplastic large cell lymphoma. I certainly don't harp on it, but I do educate each one because it's a partnership. I want them to be educated and make the decision with me. I do think I'm putting in less textured devices. I still use them. There are still some patients that in my practice will benefit from it. If you've got recurrent capsular contracture, you got bottoming out, I give you the option. I say, hey, listen, this is the data. I think a textured device would be a good option for you, or mesh. We do kind of a risk cost analysis, and we decide together. So this is something I still use in practice. I mean, I like some of these devices. I like shaped implants. I have a lot of thin women that want a very anatomical natural augmentation in a subglandular plane because they don't want the downtime because they're professional women. I have a huge subset of these, and these are textured devices. And so we have a conversation. I mean, there's a certain amount, type of texturing I don't use anymore if I do use it, but it doesn't decrease their chance to 0. So I think it's just a conversation. I have textured anatomic devices myself. And so this is not something I'm thoughtful about, but I'm not particularly worried. Since we have discovered this in 2010 and we know what we're looking for, there's been 0 deaths because of it. You take out the implant, you take out the capsule, may or may not chemotherapy. I mean, I'm not trying to downplay it, but there's risks to everything you do. And thank goodness this is something that is manageable, and we can recognize it now. We know what we're looking for.
Yeah, the Plastic Surgery Channel is launching a deep dive on breast implant ALCL from the patient's perspective. It's actually with 3 BIALCL patients. And it's actually very interesting. Their perspective is that the awareness needs to be better, but it's not. Certainly some plastic surgeons need to be better informed, but there's also other doctors seeing people coming in with implants, like ER physicians and family practitioners, and they actually need better awareness because they're not necessarily up on the most modern things. But that show has been an enlightening one. Adriano, I mean, you're in Europe, predominantly a textured market. You use quite a few textured implants. What's the process for informed consent and the status in Italy?
Yes, for the moment in Italy is not exploded the bomb about BLCL, but however we inform the patient. I think that is correlated of before. If you are well-trained plastic surgeon with good technique, clean, with right implant, is not important if is textured or smooth. Important is the technique, is important the protocol. And I think that the rate, you know, there are many papers with thousands and thousands of patients. In the right operation, you have not contracture, you have not BLCL. And this is all I say to the patient. I inform that if we correctly, the rate is very, very, very rate of a very rare disease.
Yeah, I agree with everybody that it needs to be discussed, but I don't think it needs to be emphasized as some type of doom and gloom fatality that can happen. I think that eventually this is going to be a manageable disorder, and I think that it's just going to become the standard to mention it in a consent form and mention it to the patient, but I don't think it is going to make textured implants go away. It may reduce the number of cases we do. We may limit textured anatomic devices to certain cases where it is clearly the best implant, because it clearly does have a role. But I think that a lot of this can be managed, and I think that some of what we hear is a little bit too dramatic. So I think that, like anything, we have to kind of take a step back and look at it. But I think in 5 years, this will be kind of manageable.
That's some great stuff. I appreciate all the insights everybody has. We thank you for your time. If you want to see more on that, you can see it on theplasticsurgerychannel.com.